This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients. Welcome everyone to another episode on PHM from Pittsburgh. That's right, if you remember, we changed the name of the podcast to PHM from Pittsburgh. I am your host, Dr. Tony Tarchichi, here from UPMC Children's Hospital of Pittsburgh still. We're coming to you today about this is a special episode because we have our measles outbreak. And when I was sitting there reading about the measles outbreak, my honest first thought was, what if a case like this were to come to Pittsburgh, a patient were to be admitted to our hospital, and my genuine fear, would be I would see this and maybe at first glance think it's the flu, we're in flu season, or some other virus and miss it. And then that would lead to a big increase in the outbreak of how infectious this is and how contagious this is. So I thought, I have to read about it. So I started reading about it, and then I thought to myself, I can't be the only person in the country who's had this fear. So we have the podcast. I thought we'd do an episode on it. So I do want to introduce our very special guest, friend of the podcast, Dr. Andrew Nowalk, who's an associate professor of pediatrics and the clinical director in the Division of Infectious Disease, the Department of Pediatrics at UPMC Children's Hospital of Pittsburgh and the University of Pittsburgh School of Medicine. He's a 1999 graduate of the MD Ph.D. at the School of Medicine, completed his pediatric residency and infectious disease fellowship training here at Children's. Then he joined the faculty of the School of Medicine in 2005. He has a clinical practice, active research program in Lyme disease. We had him on for our Lyme episode. And serves both as an advisory dean for the School of Medicine and as co-program director of the Pediatric Residency Program. He has participated in the Allegheny County Immunization Coalition in past years and lectures at the School of Medicine on strategies to combat vaccine refusal. So there isn't anyone better to help us with this. Andy, thank you very much for coming back.
Tony, thanks for the invitation. I appreciate it, especially for this topic.
So why don't we do our standard conflict of interest? I have nothing to disclose.
And I don't have anything to disclose either.
So the way we were going to go about this was I've done a fair bit of research on measles for this podcast. For those of you at home who are listening, I've read Peds in a Review. They're in brief by Sarah Calderaro. And let me just, again, my usual disclaimer of if I mispronounce anyone's name, I do apologize. I'm not doing it purposefully. Volume 28, number 9 is September 2007. And then the Peds in Review in brief on measles, Volume 37, number 5, May 2016. Of course, the AAP Red Book, and an older Pediatrics in Review, larger article on measles, I believe in 1992. So that's what I read to put this all together. So let's talk about what I learned. So first, measles, we'll talk about the clinical presentation. So it's an acute viral disease. You have fever, cough, coryza, and conjunctivitis. Now, for those of you listening in your car and you're like me and you forget what coryza means because you only associate it with measles, I looked it up from Google. It's a catarrheal inflammation of the mucous membranes in the nose, especially by a virus or a cold. And you get this maculopapular rash after the cough, coryza, conjunctivitis, and fever that begins on the face and spreads cephalocaudally. So again, I looked that up as well to be certain I was right. Head to toe and centrifugally, which is from the center out. So during the prodrome period, you got the pathognomonic exanthem or Koplik spots, which isn't a whole lot of people who get that. We'll talk about that. But according to the review articles, the early phase of measles infection, you experience a low-grade fever, cough, photophobia, coryza, and then mild to moderate GI symptoms. Once this happens, you're highly contagious. Within a few days, you get the enanthem fading, which is the rash on the mucous membranes, the temperature rising at the beginning of the characteristic erythematous morbilliform exanthem. It evolves behind the ears and along the hairline margin. And then the rash progresses over the next 3 to 4 days from head to foot, clearing in the same direction over a similar period of time. And you have a transient brawny desquamation, which Andy and I were talking about this a little bit ago, about some of the terminology for these, especially these older diseases. Measles counts as an older disease at this point, although we have these outbreaks. But these aren't terms we use regularly in medicine anymore. So at a time, I'm sure we all, without thinking, knew what coryza was. But if I'm being honest with you, and that's what I try to do, I forget. I have to look it up. I have to regularly look it up because I only use it for measles. So we talked about the rash. Then let's talk about the complications. So who's at risk, according to what I've read, for having severe complications or fatality rates? They're increased in children younger than 5, children with leukemia or HIV, or severe malnutrition, specifically vitamin A deficiency, are including. 1 in 1,000 patients will develop an encephalitis, often leading to residual brain damage. There's a lot of secondary bacterial infections, otitis media, bronchopneumonia. Of course, there's an autoimmune reaction. 1 to 2 per 100,000 children have a persistent measles infection that results in subacute sclerosing panencephalitis. The mean incubation period for SSPE, that's what we're going to call subacute sclerosing panencephalitis, is about 10.8 years. This is a degenerative brain disorder marked by insidious cognitive and behavioral deterioration, ends in dementia, blindness, and decortication. And then live measles vaccine risk for SSPE is about 1 per million. There's also croup. Now, according to the Red Book, this wasn't in the Pediatric Review articles, in the U.S., in the post-vaccination, what they call the post-elimination era, where we're really seen as a big decrease, death from measles predominantly results from respiratory and neurologic complications. And it comes at a rate of about 1 to 3 every 1,000 cases reported. So now, we've talked about how it presents, we've talked about treatment, we've talked about, complications. Now let's talk about treatment. And from what I've read, treatment is primarily supportive. The WHO does recommend a 2-day course of high-dose vitamin A for all children with severe acute measles who require hospitalization, even in countries where the disease is usually not so severe, I guess, like the U.S. So let's stop for a second. Andy, is what I've said from what I've read correct? Anything you would adjust or change?
Now, Tony, I think you reflect a lot of the fact that, coryza sounds weird to use, cephalocaudal, morbilliform, enanthem, Koplik spots. These are old diseases and a lot of old terminology still stuck to them. And they're those challenging diseases that we learn about in medical school and then we don't get an opportunity to see. And, if we were sitting here 15, 20 years ago when U.S. measles cases got down into the 20s and 30s in terms of the total case number, we were, really glad that we had gotten to a point where measles was so rare. Well, unfortunately, given vaccine refusal in the United States, and especially the concentration of vaccine refusing communities in the United States, where you can have local rates of vaccine refusal in the 50, 60, 70% range, we are now a country that's very well primed for measles outbreaks. And if you look in Europe at this time, and you look at vaccine rates, they're even worse, and they've had an even greater decline than in the United States. And so if you look at places like Italy and France and Germany, even the UK, there are measles cases, thousands of them every year, and there are measles deaths pretty much every year. And I think what we're looking at here is an old disease that is new again because of vaccine refusal. And I think you really outlined it very, very appropriately. And you can, if you think about what we just spoke about, you can understand why you would be nervous, because measles in the first stage of the infection gives you, we say the 3 C's, cough, coryza, conjunctivitis. Let's just say viral syndrome. That's an influenza-like illness to a certain extent. You have a child who comes in coughing, they have nasal discharge, and they have some pink eyes. So what's to differentiate from influenza? Adenovirus, enteroviruses, parainfluenza viruses, not much at that stage. And an experienced clinician back in that time couldn't distinguish them reliably from the other viral infections. And that's why Koplik spots became so important. Koplik spots, which is the rash on the mucous membranes, the enanthem, are one way that you can identify a case in that early nonspecific stage. When it progresses to the next stage, as you highlighted, measles becomes a very distinctive rash. And so the morbilliform or measles-like rash, that's literally what it means, is going to start on the upper part of the body, particularly the head, and it's going to be most coalescent there, but then it's going to move down the body. And, I was always taught it's like a can of paint dumped on the head, very coalescent on the head, much more discrete as it moves down the rest of the body. And as you said, moving from the torso on out, moving from the head on down. At that point, measles is more distinctive, but again, it's so much harder to recognize diseases we don't see frequently. So a measles case, the last time we had a measles case at our hospital, which is now several years ago, it came into our emergency department and was thought to be Kawasaki disease. So you can understand how seeing other things that are much more common, because Kawasaki is much more common than measles in the United States even today, you might mistake a measles case along the way. But
one of the things I wanted to ask you, because one of the things I learned is the term measles. Kids look measly or look just terrible. Similar to Kawasaki's kids, where they're fussy, irritable, they look sick. Is that true?
I think the intensity of their illness, the toxicity of the child, is always something that's written about measles that helped to distinguish a child with measles from another garden variety respiratory viral illness. The intensity of the rash, the intensity of the toxicity. It's interesting, if you go to the Red Book and if you look at the pictures that the Red Book has of measles, you will immediately have your pediatric hackles go up because you're looking at these children and they just in the picture look so ill. They look very acutely ill with measles. So it's a very severe disease. And as you said, the secondary complications are actually very common. Things like acute otitis media. An estimate of 10 to 20% of children with measles will develop acute otitis media. Pneumonia happens in 1 to 5% of cases. Pneumonia can be lethal in a lot of those cases. GI dehydration from the pneumonia or the gastrointestinal symptoms or just the toxicity of the illness can be life-threatening. And the big measles outbreak in the early 1990s in the U.S. in Philadelphia, which was really one of the epicenters of that outbreak, the majority of children were dying from dehydration in that outbreak. So the symptoms can be very severe. And we think of the encephalitis. We always talk about that 1 in 1,000 encephalitis as being the big problem. For me, I really think about pneumonia. And I think about measles extending to the immune compromised. But recognize that measles is fatal in 1 to 3 out of 1,000 children who get it. That's a really high mortality rate for an infection like this. And so when we see 100 or 200 or 300 cases of measles, and so far in the United States, just this year, we're in March, we see 300 cases of measles, 300 plus cases so far, you're going to start to see deaths. So if you just keep an eye on the CDC's ticker, eventually you'll see some immune compromised patient, I would predict in the Pacific Northwest or in the New York City area, is going to die from measles because they will be immune compromised and they'll get it. And as you said in treatment, the best treatment we have for this is vitamin A. That tells you about the status of treatment for measles. So we're extrapolating from CDC and WHO studies that vitamin A helps. We have no effective antiviral. And in fact, our most effective tool for the treatment of measles is to prevent the case in the first place.
With the vaccinations. All right, so then let's get into the measles vaccine. So facts about it, just so you all know, because parents are going to give you all types of alternative facts. We use a live attenuated vaccine, is that correct?
Mm-hmm.
The attenuated virus was grown in cultures of chick embryo fibroblasts, stabilized with human albumin, sorbitol, hydrolyzed gelatin, and a small amount of neomycin. You get a fever, if you get a fever from the vaccination, it's probably 6 to 12 days after the vaccine, especially if you give it with MMR, and 5 to 15% of recipients usually get this fever and may last a day or so. You can get a transient measles-like rash from the vaccine, occurs in about 5% of people, and that will occur 7 to 10 days post-vaccination. So the fever and the rash can occur simultaneously or one after another. And usually both these reactions, the fever and the rash, occur much less frequently after you administer that second dose of measles vaccine. A transient thrombocytopenia is a less common reaction. Seroconversion rates, these are between 95 to 98% in an antibody response to first detectable, and are first detectable for 12 to 15 days after vaccination, and peak titers at 21 to 28 days. The antibody response includes IgM, IgG, IgA, and secretory IgA. And loss of immunity after initial seroconversion, which they call secondary vaccine failure, is believed to occur in less than 0.2%. So if you want to understand this, it's people who get the vaccine and over time lose the antibodies to allow them to respond. It's a very, very low number. Primary vaccine failure, meaning in that first dose, those who will lose their immunity before their booster, is about 7%. And people who have gotten a single dose of vaccine at 12 months of age, which I assume is why you need that second dose, because 7% is a much higher number than 0.2.
Absolutely, yeah. I think when you look at the history of measles vaccination in the U.S., which started in the 1960s, recognize, first of all, the amazing power of this vaccination. So there were 2 to 3 million cases of measles a year in the United States that resulted in 500 dead children every year, and many adults who would pass away from complications of disease like SSPE. So this is an amazing vaccine in that it's brought down 2 to 3 million cases to a few hundred cases a year now that are primarily spurred by external sources coming in and delivering it from another country. So very effective vaccine. But when we first started doing vaccine with a single dose, we recognized that there was a certain number of people who were not going to respond to the first dose. And we recognized this primarily because in the 80s and then into the early 90s, measles cases, after bottoming out with the introduction of vaccine, began to come up again. And so in the early 90s, there were big outbreaks. I mentioned the Philadelphia case a little bit ago. So we saw increased cases. And what we recognized is we needed to capture some of those first dose non-responders and give them vaccine immunity. It's not so much of a boost as it is that second dose, as it is some way to capture the folks who didn't respond to the first vaccine. So when you give 2 doses, you can get about 95% of the people who are exposed to vaccine to develop good productive immunity. And that's a pretty standard number. The problem in the United States, as I mentioned, is that we are at about 92 to 94% coverage on average throughout the United States with MMR vaccine. And when you think that we're going to protect 95% of people, and you do that math, we're always going to have a chunk of people who are susceptible. And then you take communities like we have in New York City, where the outbreak that's occurring now is occurring in the Orthodox Jewish community, or on the West Coast in Oregon, where the outbreak was occurring in a community, a relatively affluent community, who were very focused on vaccine refusal with a very high rate. And you can see that you're throwing a match into a very susceptible population, and the measles outbreak is going to burn. Interestingly, if you drop one of those cases in Pittsburgh, I'm glad that you're concerned about it, but it would probably die out quickly in the Pittsburgh area because of the high level of vaccine coverage we have in our community. However, we have Amish communities nearby where there are some holes in that coverage. And if you get into Philadelphia on the other side of the state, you'll find some communities with lots of vaccine refusal. This is a really big public health issue we continue to confront.
So now you brought up the population immunity is about, you need more than 95% to stop ongoing transmission. It's extremely highly communicable of all infectious diseases. The attack rate in a susceptible individual exposed is 90%, which I did not know.
Oh, yeah.
So that's extremely high. In temperate areas, the peak incidence of infection usually occurs during the late winter and spring, which is exactly where we are. And then, of course, the only natural host of measles virus is humans. And then you get it's transmitted by direct contact with infectious droplets or even airborne spread, but that's less common. And I don't have this written down, and I hope you know this. If you're in a community that's exposed, and then you have a patient who you can talk into getting the vaccine who doesn't have measles, how much time do they need for it to have some effect?
So that's a great question. What's the duration of time before immunity? In general, 7 to 10 days, they'll start to make antibody. And this is useful enough that if you have someone who is exposed to measles directly, in the first 72 hours after exposure, they should get vaccine because the vaccine will act quickly enough to stave off a new case of the measles in that person. After 72 hours or in immune-compromised hosts, we would typically use IVIG or intramuscular immune globulin to try to stave off cases of measles, but the vaccine's effective enough and it's fast enough, faster than natural measles, that it can prevent the onset of disease. So we really, really want to be using as much vaccine as we can. We want to vaccinate all our unvaccinated if there's an outbreak in the community. We want to hit those who've gotten one dose with a second dose. Because remember, you can give that second dose as early as 28 days after the first dose. So if you had an outbreak in your community, let's say, and you had a 15-month-old who got their measles vaccine at 13 months, give them another dose. We want to do everything we can to make sure they're immune to measles. It's a very important concept. You can even give vaccine in an outbreak situation to infants down to 6 months old. And so in an outbreak situation, in order to protect those infants, we'll vaccinate them knowing that one of two things is going to happen. The first outcome is that they didn't get enough antibody from their mom, therefore they'll make a good response to the vaccine, and 93% of those infants are protected. Or they have a lot of antibody from their mom. The vaccine won't work at all, but their antibody from their mom will protect them against measles. So either way, that baby 6 months and older wins. Those infants, it's important to remember, will need their regular vaccine schedule to kick in again after the age of 1. But we can use vaccine as our most effective medicine in an outbreak to prevent secondary cases.
So you can give a vaccine to a kid as young as 6 months of age. A kid who got a first dose can get another dose as soon as 28 to 30 days after that first dose. And then up to 72 hours, if somebody exposed, you can give them a vaccine to help them mount a response to protect against some of these bad side effects.
Absolutely. We have a lot of options to use measles vaccine as our most effective tool for treatment, quote unquote, of that.
And outside of that time period, or an immunocompromised person, you would use immunoglobulin.
Immune globulin, either intramuscular immune globulin or IVIG. Either product should be helpful in those. In those cases are really, if they have an exposure, very, very vital that they get some antibody in them to protect them. Measles in the immune compromised has a much, much higher rate of fatality even than measles under the age of 5.
Let's talk about this outbreak that's going on now. What can you tell us? What do we need to know?
Well, I wish I could say that it was one outbreak that we've gotten under control, but it's not. Here in 2019, unfortunately, what we have are multiple outbreaks around the United States. And as I said, 300 cases just so far in March. Let's say we keep up at the rate that we're going now. That would mean in the year we'd have 1,200 cases, which would be our largest year since the early 1990s. We have vaccine refusals, but a real problem in our country. And we've made some progress in places like California. Richard Pan, who's a state senator there and a pediatrician, pushed through a California State House bill that eliminated philosophical and religious exemptions. And so there are some places we've had success. There are lots of communities around the United States, in California, in Washington, in Oregon, in Texas, and Pennsylvania, in fact, where there are enclaves of high levels of vaccine refusal. So this outbreak, quote unquote, that I'm talking about in 2019 has happened in Oregon, it's happened in New York, and if you look at the CDC website today, as I did before coming in, there are 6 different places where there have been a significant number of cases. In Oregon, there's been 70 plus cases. In New York, there's been more than 100 cases. So we have these fires kind of picking up all over the U.S., emphasizing how important it is for us to really talk to our parents and patients about vaccination.
And as you said, as far as the CDC website is concerned, there have been no reported deaths from measles.
There have been no reported deaths, but once you see 100 cases, you're going to start to be at risk for having people die from measles. When you look at the UK, and the UK is a very useful case in point, high vaccination rates until the late 90s, when Andrew Wakefield published his very irresponsible article purporting to find a link between autism and MMR vaccine. As it turns out, just for the listeners, we all know now that Andrew Wakefield was in the employ of a law firm looking for cases. He was trying to file his own patent, and so trying to discredit the current vaccine, and faked most of his data. So not only was his paper retracted by all the authors, his license was removed, and he's no longer a practicing physician in the UK. However, that data got out there and signaled a significant reversal of vaccine rates in the UK and across Europe. And ever since then, you will see deaths every year in the UK. So not hundreds, but thousands of cases. And so we see a very, very regular, low-level measles endemicity in the European continent as well as in the UK, and that gives a supply of cases to come over here as well as from the Pacific Rim. So unfortunately, most of our outbreaks start with a non-vaccinated person. 2015, it was an unvaccinated visitor coming to Disneyland. But it was Disneyland. So you drop them in Disneyland where there are a lot of Californians wandering nearby who are unvaccinated, and you're going to see a ton of follow-up cases. When we see these outbreaks, we see tons of cases in the unvaccinated and very few in any vaccinated individuals.
That was my next question. The kids that are vaccinated, we're really not seeing them have any trouble with this.
The kids who are vaccinated in general, their risk is dramatically lower, and we do think that a vaccinated individual will modify the disease too. Kind of like influenza. Right. You know, we always focus on these news reports of influenza vaccine efficacy, which is the prevention of infection with influenza. So it prevents culture-confirmed influenza, and we think to ourselves, oh, you know, last year's vaccine was 30% effective. What a failure. Well, recognize that influenza vaccine, that's the base rate where it keeps you from being infected at all. But we have good data to show that even if you're infected with influenza, in pretty much every year of vaccination makes it less likely when infected that you'll have to go to the emergency department, less likely in the emergency department that you'll be admitted, less likely when you're admitted that you'll go to the ICU. So you have to, I think, really look at not only the straight up efficacy, that is how well a vaccine prevents a new case of infection, but if you're infected, is it going to modify the disease and keep you safe? And we know that just like flu vaccine, that MMR keeps you safe. Measles vaccine works well to decrease the severity of disease.
So are these kids presenting, do you know if they're presenting classically, exactly like we described in the podcast earlier on?
So what a great question, Tony. I think that when you think about measles pathogenesis, the kids who are unvaccinated are much more likely to present like measles. So they're likely to have, the URI symptoms beforehand, that cough and runny nose and conjunctivitis. They're likely to have a pretty significant rash with it and high fever. Koplik spots, I love Koplik spots, but I have to say I tend to observe Koplik spots mostly on the pages of things and not in patients because I've seen very few measles patients, and they're not in every patient. In a patient who's vaccinated, it can be harder because they are less likely to have a completely typical case of measles, and they may be modified significantly, have less rash, have less fever, have less toxicity than an unvaccinated patient would. And I say for that, yay to the measles vaccine. Yeah. It tells you the vaccine works well even if you do get infected.
Do we know if any of the kids that in our current outbreaks going on in the country have had any of the severe consequences, encephalitis and pneumonia, anything like that?
I don't know enough about the individual case reporting yet. And because we're so early into 2019, a lot of that data is still being gathered by the state health departments and the CDC.
Okay. So is there anything else we should know about or you want to talk about for the measles? Because that's what I wanted to cover. Then I wanted to move on to this year's flu vaccine and our current flu season, which was like it's never going to end.
I think that the measles vaccine takeaways are, number one, you need to think about it, particularly if you have travelers who are coming to those areas or coming from those areas where there are burning outbreaks. I would say that I would be more likely to have a higher index of suspicion now than ever before. I would be wary of modified cases, particularly in children who've received vaccines. And I would recognize, as you said, the unbelievable infectivity of measles. Measles is one of the few infectious diseases like varicella and tuberculosis that can be transmitted through airborne particles. So now we're talking about N95 masks, and we're talking about PAPR suits, which are the little over-the-head ventilator-type suits that make you look like a spaceman. It's secondary case rate. We call that the R-naught. Right? So R-naught means if Tony, you have measles, how many people in your office setting would you infect, likely on average? For influenza, the R-naught's often around 1 to 2. For measles, it's in the double digits. So this is an incredibly infectious disease. This is why there were millions of cases a year in the United States every year. And I would remember that because it can be transmitted very efficiently and very effectively, and it can kill children and adults very, very easily. So you have to keep it on your radar. And the last thing I'd say is go to the CDC website. Their information is amazingly well put together. It's updated. There are flyers you can print out for your patients in your practice. There are educational materials for physicians, both online PDFs, webinars, and the like. And you can get up-to-date reporting on all the outbreaks that we have.
The last thing I do want to ask is, I'm a hospitalist, and if I'm lucky enough, like I am in a hospital that has a good pediatric infectious disease group, I'm not going to wait long if I'm suspecting measles before I call your division. I'm assuming that's what you all want.
Oh, absolutely. If you have a concern for measles, we would like to be involved in the emergency department if possible. If you do not practice at a place with a good pediatric infectious disease service, I would call an adult infectious disease doc. All infectious disease practitioners are interested in tamping out these outbreaks as quickly as possible, and recognize too that in any situation measles is reportable, and your local health department as well as your state health as well as CDC will want to know about that immediately if you have strong suspicion that there's a measles case, because they know that when there's one, there's likely to be others after that, and they'll want to investigate that and provide resources.
So now let's switch gears. We're in the flu season. I feel like I'm diagnosing flu left and right now. March is late, I feel. Then last year was the same thing. We had a big March year for flu. Are we seeing flu get pushed later and later?
So, Tony, first of all, I will give you a disclaimer that, you need to talk to John Williams in my group and Marion Michaels. John is our division chief of pediatric infectious disease here at UPMC Children's. He is a respiratory virus expert and participates in national studies, the National Vaccine Surveillance Network. He's the lead PI here, as is Dr. Michaels, my colleague, who has a strong interest in vaccine-preventable diseases. However, I can make some general statements that I'm pretty sure are true. Okay. Number one, flu seasons, one to another, are just hard to compare. So to say, flu's getting later means that you've seen a flu season. That's the old adage in infectious disease. If you've seen one flu season, you've seen one flu season. And they vary based on pandemics, on epidemics, on changes in the virus, on changes in the vaccine. Sometimes we'll have a particularly early and severe season. Sometimes we'll have a very modified season throughout. Sometimes that's influenced by the strain of virus. Sometimes it's influenced by the efficacy of our vaccine, really suppressing cases. And we've had in the recent years more trouble with H3N2 as our primary virus. Everybody remembers 2009 and pandemic H1N1. So the virus strains that are the big ones from year to year change, and that has some influence on timing of the season as well. But we do have seasons where H1N1 shows up really early and then we burn for the whole season, or this one where we had a really mild start to the season, and then at least here in Pittsburgh, we had a February and a March that were filled with influenza. That is very variable around the United States, and the thing that I would look at is every state reports their flu cases to the CDC. If you're wondering when you typically have your flu season, go to your state health department website or the CDC website. Their resources for looking at flu data called Flu View are fantastic and allow you to kind of map what goes on in your state over a period of years and get a sense of where the flu seasons sit.
Flu View.
Flu View.
Okay. Now, how is our vaccine this year?
Vaccine this year is more effective than last year's vaccine. So we're very pleased with the match of vaccine to circulating strain. The story behind that is it's a tough one in that we look at strains that are circulating in the Far East, especially in the Southeastern Asia region, where a lot of flu seems to originate and then eventually move into the United States in subsequent seasons. And so every vaccine that we make's a guess. Unfortunately, we can't wait around to see what's coming up because then we wouldn't have vaccine on hand and we wouldn't have vaccinated everyone. So it can be very challenging to pick the strains. This year we did a lot better. And so the match seems very good. The efficacy estimates that I've seen so far range as high as 65% in children. And 65 to 70% in children is a really good flu vaccine. When, as I said before, that's efficacy. It's preventing influenza infection. Think of the number of kids that is saving hospitalization, and think of the number of children that's saving from ICU visits. Nonetheless, we're seeing pediatric deaths, as we do every year. We're seeing a significant number of them because we have a lot of vulnerable kids who themselves cannot get vaccinated, who get influenza because our communities are not good enough in terms of vaccine coverage.
Yeah, the one thing I have noticed is we have not seen a lot of kids who are vaccinated coming into the hospital unless they have significant comorbid issues, bad asthma, neurodegenerative, neurocompromise, neurodevastation, something like that, to where they're very vulnerable. But I have not seen a lot of healthy kids coming in. Last year we saw a lot of kids with flu coming in with diarrhea, dehydration, those things, I have not seen a lot this year. It's really been a milder year for those kids. Now, I've seen a lot of kids come in unvaccinated with all types of issues with the flu.
Well, I think you're reflecting when the vaccine works well, it's really going to have a major effect on those healthy kids who get vaccinated. The myth of influenza in pediatrics is a lot of parents think my child is healthy and therefore I don't need to vaccinate them. We have pediatric deaths every year in healthy children. Yeah. If enough children get sick, they're going to die from influenza. They will. It's just an absolute certainty. So saying my child's too healthy to get influenza is not thinking that holds up. And those kids really need it. And they need it for two reasons. Number one, I'm going to amend that. 3 reasons. Number one, to protect that child. So as we said, when we look at comorbidities and we look at pediatric influenza deaths, it's typically about 50% of the deaths happen in children without comorbidities. So that means that we take care of healthy children who die of influenza every year. The significant majority of those kids are unvaccinated. So they could have been saved with flu vaccine. Number 2, they protect the parents. So I think parents miss out on that all the time. That the way that they could potentially get influenza is from their children. And influenza is not a benign disease. I had flu about 10 years ago, and it was absolutely miserable. It really knocks you out. But the third piece is, and this is where I think flu vaccine for me is a moral good. These children with leukemia, HIV, on steroids for their rheumatologic disease, on biologic modifiers for their inflammatory bowel disease, who just had a bone marrow transplant, who just had a solid organ transplant, those children don't have the option to choose to be well protected against flu because of immune suppression. To stay alive, they need to take drugs that keep them from developing a good immune response. They are relying on us to protect them. They're relying on their community to protect them. So it's very frustrating to me when I see communities go to great lengths to support children who have leukemia or solid organ transplant needs, and yet everybody in that community doesn't do something that would benefit them as well, which is to go get the flu shot. So it can be very, very frustrating because a lot of those children never have the option to get vaccinated.
That's very true, and I can't tell you how much I appreciate your time today. We have gone through, and this made me feel better because I was genuinely worried about a measles case coming in, and it sounds like at least Pittsburgh right now is doing a good job in terms of vaccination. And hopefully for those areas in the country that are very much affected by these outbreaks, I hope they end soon and we stop getting kids who have them. Hopefully parents will vaccinate, but that's a whole nother podcast. And
that's a whole nother podcast. That's the last public service announcement I'd make, Tony, is that this brings up again the critical role of talking not to patients and parents, but talking with patients and parents about vaccines. All of the CDC data says that in the majority of cases, consistent, respectful, effective communication will turn the vast majority of fence-sitting parents around about vaccination. So take that extra bit of time. You could save that child in your community who can't choose to be vaccinated.
That's a great way to end. So again, thank you very much, Andy. I appreciate you being here. I appreciate your time. For other acknowledgement besides my fantastic guest, friend of the podcast, Dr. Andrew Nowalk, is, of course, the UPMC Children's Hospital Pittsburgh for continuing to allow me to do this. My division, the Paul C. Gaffney Division of Pediatric Hospital Medicine, for supporting me through these podcasts. All of you listening at home, thank you very much for your time. Of course, Dr. Megan Keene Tarchichi, who helps me with everything. We are going to try to get another podcast out to you as soon as we can. I believe we're going to continue down the rheumatology trend, but there's so much to discuss, toxicology and other things. We're going to get as much out to you as we can, but of course this is a labor of love, so I'll get to it as soon as I can, everyone. Feel free to email me with any ideas, suggestions. Thank you all very much. This is PHM from Pittsburgh. If you have any suggestions or comments for a podcast, compliments or anything, please feel free to email me at tony.tarchichi, tarchichi, @chp.edu. We'll see you next time. Thank you.